Okay, good afternoon, everybody. It's my great pleasure to introduce the next speaker, Doug Altman. Professor Doug Altman graduated in statistics from the University of Bath. His first job was in the Department of Community Medicine at St. Thomas's Hospital. He's worked 11 years for the MRC, and he's a statistical consultant, and he has published widely. And he now runs a Centre for Statistics in Medicine in Oxford. And I've got an output of this meeting. I've arranged to have coffee at least once a month with Doug in Oxford at 9 o'clock. So that's my one innovation for the week, if you like, for the session. So I have the great pleasure in handing you over to Doug Altman.
Okay. Okay, thank you very much indeed. I was asked to talk to you about reporting, and in particular the impact of the way research is reported on the evidence base. And there have already been several mentions in the sessions I've been to that link into this, I think, rather nicely. So let me start by observing that reliable evidence is key to clinical practice and public health policy. Decisions in both contexts depend on having high quality information about research findings. We need research and we need reliable evidence from that research, and that means that the research has to be of a high quality, which I'm not going to address, although clearly that's not easy to define. But we also need good reporting of that research, and that is what I am going to talk about. And there's a note to myself, really, just to remind myself that although the principles of what I'm going to say apply to all types of research, I shall talk almost entirely about randomized trials. But I want it to be clear to you that what I say isn't that specific to trials. Research articles are the public face of research, and the scientific manuscripts which turn into journal articles should include sufficient information, data if you like, so that the reader of that article can fully evaluate the information, how the study was done, and reach their own conclusions about the findings. Are they of relevance to them, and are they reliable? So all readers need a clear understanding of exactly how that study was done, whether they are clinicians, researchers, systematic reviewers, policymakers. We've heard about all these groups today, and indeed other groups. In some sense, this is entirely obvious, and it should be clear to people when they write journal articles that the purpose of writing a journal article is communication to the reader. It's not obvious, though, if you read many articles, that authors have that in mind. And the objective, I fear, too often is publication itself as the end process rather than communication. This is a fairly obvious idea that clinical trials will really be only as strong as the weakest element of the design, the execution, and the analysis. But clearly, if you imagine a big cloud over the front of that picture, you can't tell the quality of that chain. So, we need transparency. Poor reporting of research doesn't help anyone, and in fact, it's harmful. But by poor reporting, I mainly mean that key information about a research study is either missing, or it's incomplete, or it's ambiguous, and that can apply both to the methods of the trial and also to the results of the trial. Another possibility is that although those aspects are largely fine, the interpretation may be misleading. I'll come back to all of those issues. So let me amplify that a bit. Non-publication of research is the first thing I'm going to talk about, and that's surfaced already in the session I was at just before lunch. Non-publication of research findings will always lead to a degradation of the evidence base, because there'll be information that's missing, regardless of why that information is not in the public domain. But the main concern is that non-publication, or indeed misleading publication, will be driven by the study findings and therefore produce a distortion of the evidence base. And the most obvious example of that is the first line in black here, where some whole studies are simply never published. Or possibly, less seriously, but still of concern, that some studies are published, but after some delay. We also know we have the problem of selective reporting of only some of the outcomes in randomized trials. We know, in fact, all the things I'm going to say here, that we have empirical evidence that all of these things happen, and in fact that they're quite common. And this evidence, in some instances, is quite recent. So it's not simply a phenomenon of 10 years ago, say. We have several examples of inconsistencies between data sources, between trial publications and trial protocols, or between publications and registry information. We know that many trials are published but present the data in such a way that the information is incomplete and cannot be included in a meta-analysis. And I think that is another key consideration about how research should be published, that possibility should be there. Clearly, we would be concerned about crucial aspects of research methods that have not been mentioned. And then, as I mentioned before, there's the issue of misinterpretation. Possibly we might call that spin, whereby the author's conclusions are at variance with what they actually found. And one way that's often done is by a post hoc change of focus, changing to a different outcome or a subgroup or a different time point. And lastly, not to be forgotten, is abstracts may mislead, and many more people read abstracts than read articles. At least that's what I'm told. I'm not actually sure about the evidence for that, but it seems that it's certainly true for me, and I think we need to remember that abstracts are important and not something that should be written in 5 minutes just before sending it off to the journal. So as I say, there's empirical evidence that all of these are very common things. There are hundreds of published reviews of published studies, in particular reviews of published trials. We recently published a review of 177 reviews, I think. This is big business. Most of these have been published in the last 10 years. The consequences of all of these reporting problems, not just the missing studies, but also the deficient reports of studies which are published, I believe are quite serious for clinical practice, for other researchers, for policymakers, and ultimately for patients. And it's simply not acceptable that this should happen on such a wide scale. So I'm going to give, in a minute, a few examples. Well, I'm going to do it now. And these are deliberately chosen to be recent examples that have come to my attention. So here's an example of a review of adverse events in randomized trials of HAART, that's antiretroviral therapy in patients with HIV. This is a systematic review, 49 trials. As you can see, only 16 of the trials reported all the adverse events. The other 2/3 only reported some of the adverse events. And these are quotes from the paper, either the most frequent ones or the statistically significant ones, or quotes selected adverse events, whatever that means. And these authors wrote, these facts obstruct our ability to choose HAART based on currently published data. So here we have a review. We've got 49 publications. I mean, putting aside any issues about any other studies that might not have been published, it's not possible to extract usable and useful information from these articles. These articles are not fit for purpose. Earlier this year, a review was published of trials of interventions for acute ischemic stroke over a 50-year period that it was known were completed but had not been published in full. And they found of this cohort of 904 completed trials, 20% had not been properly published. And they noted that several of those may be large enough to influence clinical practice and the findings of systematic reviews and meta-analyses. Clearly, we hope those last two things go together, really. So again, there's a major deficiency in the available information. And this one, a paper published recently looking at breast cancer, new drugs in breast cancer, a comparison of the results of trials on 3 new medicines for advanced breast cancer, comparing the publications with what the Food and Drug Administration had, showed that the analyses reported in journals were of lower quality and were given a favorable interpretation by minimizing toxicity and ignoring methodological shortcomings. And of course, anyone reading those articles, all in high-impact, high-prestige journals, would be unaware of these discrepancies from what was sent to the FDA. And in The Lancet some years ago, they said in an editorial that the idea of a drug's use being based on selective reporting of favorable research should be unimaginable. It should be unimaginable, but it isn't. And if you go to systematic reviews, I took these 2 quotes from Cochrane Reviews a couple of years ago. The first one saying there was a big problem about the quality of reporting, you couldn't judge the methodology of these studies, and the second one on data reporting, 15 trials identified for a review, but they could actually only extract usable data from 4. So the waste here is quite shocking, that these trials are done, they know about them, in many instances they were published, but they didn't give the information in a usable form. So what should be reported? Well, here's a quote from the guidelines of the International Committee of Medical Journal Editors, who say that authors should describe statistical methods with enough detail to enable a knowledgeable reader with access to the original data to verify the reported results. Now, as a statistician, I've always thought that was an admirable sentiment, but it occurred to me not that long ago that it's a very strange statement, because why are they only saying that about statistics? Surely the same principle should apply to all key aspects of research publication. The methods for selecting participants, the exact definition of interventions, outcomes, and so on. The goal here should be transparency. The paper should not mislead, and it should allow replication in principle. As a goal, I feel it should be thought, in the investigator's mind, in principle, somebody should be able to repeat my study from what I tell them I did, at least as an aspiration. I realize there are practical difficulties. So some years ago, we did a review of 500 and some randomized trials published in 1 month in December, and these percentages show the percentage of trial reports that failed to report key bits of information. And I draw your attention in particular to the last 2 rows, which relate to 2 essential elements of the randomization process, because it is randomization that makes randomized trials head and shoulders above other forms of evidence. And yet here we have 4/5 of publications failing to tell you how they actually did that one step, which is the most important credibility element of those studies. And I'll come back to that review in a moment. So whose fault is this? Well, I would say that this poor reporting indicates a collective failure of everyone, of authors, peer reviewers, editors, at least, on a truly massive scale. But I'm not sure I wish to absolve other bodies like funders, medical educators, ethics committees, and whatever you might like to put in those 3 dots at the end. Now, of course, it may be that researchers don't know what information they should put in the research report, but surely then the peer reviewers and editors should tell them. But then maybe editors don't know what should be in a report either. One wonders why not, but that would seem to be the case. And so the question could be, well, what help can be given to authors? And people have been saying occasionally, at least over the last 50 years, we could do better. So the first quote here, which I think is brilliant, from 1951, basically describing, in essence, what we need to know. We need to know what was done. It's indispensable. Otherwise, you're in considerable doubt about the validity of the published work. That's what I said right at the beginning. And then Durst-Simonian in 1982 said that editors could greatly improve reporting of trials by providing authors with a list of items they expected to be strictly reported. But nothing happened really in that line until 1994. And I'm leading up to the development of the consult statement, which I hope many of you are aware of. In 1994, 2 sets of recommendations for reports of trials were published, by non-overlapping groups, the SORT group and the Acilimar group. And a meeting later in Chicago in 1995 brought members of these two groups together as the Consolidated Standards of Reporting Trials group, and they sort of merged their ideas into a consort statement which was published in 1996, and an update was published in 2001 with a long explanatory paper explaining what it was all about and giving examples of good practice. And the objective was fairly obvious: to facilitate critical appraisal and interpretation of randomized trials, and actually also secondarily we hope to encourage better quality trials. But I won't dwell on that. And in 2010, earlier this year, we published a revised checklist which now has 25 items, and a short paper explaining this, which we managed to publish in 9 journals, which is a story in itself, and a revised explanatory paper. It was published, amongst other places, in the British Medical Journal, which is great. Okay, so now, the major changes we've made to be contemporary, we change it because the evidence base keeps changing. So now I'm talking about the methodological evidence base. We've added 3 completely new items relating to trial registration, the availability of the trial protocol, and the funding. We also clarified the issue about trial design. We've added various sub-items, in particular about changes to trial outcomes after the trial commenced, because we have empirical evidence that this is extremely common, and it's a very bad thing. We've removed something about testing blinding, and I haven't time to explain why, and we've made various things more specific, and generally simplified and clarified it, so that ultimately, of the previous list of 22 items, only 6 remained unchanged. And the other thing we did in the interest of transparency is to document all the changes we made in the publications this year. And just to give you a flavor of evolution of consort, 6 papers the requirement or request was to report the planned interventions and their timing. By 2001, we changed it to precise details of the interventions intended for each group and how and when they were actually administered. And then in 2010, the interventions for each group with sufficient details to allow replication, including how and when they were actually administered, taking into account the fact that we have empirical evidence that many published trial reports don't tell you enough to allow you to implement those interventions. And similarly, for outcomes, we started with primary and secondary outcome measures. We moved on to clearly defined primary and secondary outcome measures, and we've added more words now: completely defined, pre-specified primary and secondary outcome measures, and so on. So you can see that just as medical evidence evolves, methodological evidence evolves, and the consort is trying to reflect that change in that particular evidence base and keep up to date. And so I'm sure it's seen as a living document, and that we expect it to change again in the future. We have a big problem, though. We know that maybe 600 or more journals endorse and support consort, but adherence remains inadequate, even for the most important aspects. So if I come back to the study I showed you before, I showed you data from 2000. Sally Hopewell led a study where we repeated this for 2006. And this plot shows that for 5 key features, which I think were on the previous slide: primary outcome, sample size, the 2 aspects of randomization, and blinding. Apart from blinding, we see a statistically significant improvement in reporting. But basically, although the percentages are not here, we've gone from 18% reporting allocation concealment to 25%. Yeah, that's a big improvement in relative terms, but we still have 3/4 of publications not telling us the one thing we most want to know about randomized trials. How did you randomize? Where is the difficulty in understanding that that's an important thing to include? And if we look at journals that do or don't endorse consort, we see, again, a systematic benefit in favor of journals that do endorse consort. But again, all the percentages are the wrong side of 50%. And in particular, those ones, the two about randomization, the figures are still very disappointing. So how can we improve things? Progress is there, it's evident, but it's very slow. Adherence remains poor. We must improve adherence, I believe, not because consort is the last word, and I should have said, in fact, that we see the consort checklist as a minimum. You know, there are many things which are not covered on that checklist which you would expect to see in a trial report if they were relevant. But authors, peer reviewers, and editors all have a role to play here. But there are no real requirements to do this, and there are no real incentives to do it, either for any of these groups, and that's a real problem. We are working on various initiatives to try to educate and try to improve uptake both at journals and by researchers. But as I say, the lack of incentives is a problem. This is a picture from a paper by Deborah Zarin and colleague in Science showing the relevance of trial registration, which has been a big thing in the last few years and a very positive thing. And they show various steps. The two blue elements are trial existence and summary of protocol details. That's what you find on the trials registry. The yellow is the results database, which is now being added to the trials registry. This one here, scientific publication, that's what consort addresses. And there are still two other blocks here. Access to the full protocol, access to the full data set. Anwen Chan wrote an editorial in PLOS Medicine not long ago arguing that bias, spin and misreporting, we've got to have trial protocols in the public domain. And he's actually leading a group called Spirit to develop reporting guidelines for protocols. But of course that's not the same thing as publication. These documents should all be in the public domain, and they should be published before the trial is finished so that we can have full transparency when we come to look at the publication. And there are moves also to make it easier for people to publish the raw data. I realize there are difficulties in that, but at least we now have some guidance on how to prepare clinical data for publications. But even that, some people say even that isn't enough. We should go further. This is a paper by Christine Lane, now editor of Annals of Internal Medicine, and colleagues about what's called reproducible research, which I guess many of you have not heard about. And basically the idea here is that not only do you publish the code, the protocol and the trial results, you publish the data, but you also publish the statistical code that enables you to get the results from the data. Because actually a lot of things happen between the data file and the tables you might see in a journal article which are not documented. And this is a way of basically putting the whole thing on the record. Another thing they do, and the BMJ I think also, is ask authors what they're willing to share with other people. The protocol, the data, indeed the source code for the analyses. Now most people will say nothing, but at least every time they publish they're being asked this question. And as with consort, which has taken 14 years to get to where it is, progress is happening, but it's happening very slowly. And I think people's awareness of these issues needs to precede a big change in behavior, if we can even manage to achieve a big change in behavior. Just want to mention the Equator Network, which we set up, which is a resource for information about reporting of all types of research, not just randomized trials. And we have this website, the address in a minute, and I will end by showing a slide I always end with, which says this: good reporting is not an optional extra, it's an essential component of doing good research. Thank you.
Thanks, Doug. I think we've got time for one or two questions, actually. Anybody in the audience got one question for Doug? Oh, two actually here at the front, just two here. 1 second while we get the mic up to you. Keep coming. Okay, great.
I'm Robin White from Canada. Do you think the time has come for the abstracts to be written by third-party critical reviewers instead of the authors? I think there is a very good case for the abstract to be written by a third party, or at least an abstract. I mean, it would be quite interesting then to compare the two. I like very much PLOS Medicine's style of actually having an editor's summary of the article, which goes beyond an abstract, which includes quite a bit about sort of summarizing what was done and in a narrative sense. But either somebody needs to read the abstract and verify that it's a valid abstract, if you like, or someone else perhaps needs. It's very difficult to know enough about a study to write an abstract for someone else's report, but I see a lot of practical difficulties, although I can see why you asked the question, and I can see why it might be a good thing. I mean, I guess that's what journals like Evidence-Based Medicine do, in the sense they provide a secondary review of published articles with their own interpretation.
There's one more question down here, Leslie.
Oh, hi, I'm Carlos Soares. Doug, what about data imputation or use of statistics in terms of meta-analysis when the data is not reported? I mean, I'm taking the example of the review you just mentioned that had 15 trials and only 4 had data that was usable. And, you know, if we can use some, for example, the p-value or if we input data from other studies to complete these results, I just want your view on that.
Well, I mean, there are obviously multiple problems. One of the problems is that not all trials assess the same outcomes, and so that's another problem which I think a group of people are very concerned to try to remedy, that we should have standard outcomes for a given medical condition. But the problem is, for example, when they just have a sentence in the paper that says there was no difference in side effects between the two groups. That sort of statement. So it is information, but it couldn't possibly be incorporated into a systematic or into an analysis. If you have a p-value, sometimes yes, you can do something, but not always. Unfortunately, I tried yesterday to locate the review where I took the quote from, and it's obviously been updated since, so I couldn't get back to it. I need to go back to the 2007 library to find, to check that. But it's not uncommon to find that there is evidence that the outcome you're interested in was measured, but it's not reported in a usable fashion. Then there are others where you're not sure it was measured or not. That's an additional problem.
Okay. Thanks, Doug. Fascinating talk. I've got 10 references from that talk to go and look up. And I'd like to welcome next, actually, David Tovey, who is the current editor-in-chief of the Cochrane Library since January 2009, a big remit. I first met David, actually, when he was, as previously, as editorial director of the BMJ Evidence Centre. And I learned something new about David that actually I didn't realize he was a general practitioner in your former life. So I'd like to hand you over to David Tovey.
Good afternoon. When I was invited to speak at this conference, I thought it was an opportunity to talk about the use of evidence from systematic reviews in clinical practice and health policy decision-making. I was also actually reflecting on my 15 years as a GP in South London, and my sometime failure, actually quite frequent failure in that role, to see evidence as a fundamental support for good clinical care, for which most of the responsibility clearly is mine. But I do also wonder whether the evidence-based community does enough to explain its approach to lay people and health professionals. And so here goes. One of my common mistakes was to think about evidence as being somehow authoritarian. So I want to start this talk by reflecting on the importance of the triad. The triad starts with the patient who comes with questions, values, and preferences. And the second part of the triad being the clinician, who brings their expertise and skills and their evaluation. So research evidence only makes up the third part of this triad. And in the midst of all this, in the overlapping circles, that's where the expertise lies. And I think it's really important to think about it from that perspective. I was very influenced when I was a GP by a lecture I attended by Per Fugelli, who's the Professor of Social Medicine, or was then, the Professor of Social Medicine in Oslo. And he talked about what were the building blocks of trust between doctors and patients. And there are a number of particular characteristics, but the three on this slide I think are most germane to what we're talking about. Firstly, the idea of shared power. So here we have the patient and the clinician meeting, and as a reference point in the intersection. Second, we have competence, so clearly the clinical skills and evaluation of the clinician, but also the ability to access knowledge as being a part of competence. And thirdly, realism. And I'd be really interested to think about what percentage of health consultations that go wrong it's because either the clinician or indeed the patient have an unrealistic expectation of what health can do for them. So just thinking about that research evidence, as we know, systematic reviews provide the strongest evidence to answer most questions when they're available. And of course it's really important to think about the PICO and to think about the match of the PICO and, if you're a clinician, the patient in front of you. But essentially within every systematic review there are a number of key questions, and for every comparison and important outcome there are these four elements. Is there a difference? Is there an effect? What's the direction of that effect? What's its magnitude? And how confident are we in it? So if it's that straightforward, really systematic reviews should be getting into clinical practice and health policy making all the time, and yet we know that that isn't the case, and frequently opportunities are lost. And why? Maybe it's helpful to ask why that is. And one of the reasons, I guess, is that systematic reviews are sometimes correctly perceived as complex, long, and difficult. And sometimes also questions are asked about applicability. How close to the patient in front of me are the patients in these trials? And there's also a problem of bias that Doug was talking about, in particular publication and selective outcome reporting bias. And so here we have a forest plot. And one of the reasons that it's quite difficult sometimes to interpret a systematic review is the sort of dislocation between the quality of the studies, or the risk of bias in those studies, and the results. So here we have a forest plot of a number of trials on that side. Here are the results. Here's the forest plot. And it's very easy to jump to the diamond without actually any acknowledgement at all of what the risk of bias was in those trials. There's nothing on that slide that helps you with that. And there are a number of grading systems that are used to look at the quality of trials. And these are on this slide, including the Centre for Evidence-Based Medicine, the Scottish Intercollegiate Guidelines, a number of American and Australian ones. And this can be a cause for confusion. On the whole, they tend to be study-based, so that trials are rated on a fairly rigid way according to their type. So systematic reviews and randomized trials coming above observational studies, and somewhat deflatingly, expert opinion sitting somewhere around the base. So in the first instance, they're study-based. They can be confusing. I've read these documents many times, and I could probably answer a MCQ on them on most days, but my memory's not that great, and sometimes I would still have to go and look them up. And they can be inconsistent. So here's the recommendations for use of anticoagulation in patients with atrial fibrillation and rheumatic heart disease. Here's the American Heart Association. The quality of evidence is B. The strength of recommendation is class 1. Here's the American College of Chest Physicians and SI. And as you can see, there's some inconsistency between the different approaches. As I said earlier, these approaches tend to be rigid, so randomized trials always at the top of the tree. There we have the observational data, and then again we have expert opinion, sadly, at the bottom. And this is a study many of you will be very familiar with, but it does highlight some of the problems of that rigidity. This is the parachute used to prevent death and major trauma related to gravitational challenge. And one can imagine that the systematic review of randomized trials might have concluded that there was uncertainty about the effect due to the lack of randomized trials. So to some extent, even in less extreme examples, sometimes this rigid approach of the hierarchy seems counterintuitive. So the GRADE working group was set up in 2000 and has included over 100 people, contributors in its last 10 years, looking at, and the contributors will be made up of guideline developers, methodologists and clinicians. And the aim is to develop a common, transparent and sensible system for grading the quality of evidence and also the strength of recommendations. And the way they define quality of evidence is the extent to which one can be confident that an estimate of effect or association is correct. So that's referring back to the fourth element of those 4 key indicators. So importantly, and I think this is where, as a clinician, my sort of antennae began to sort of perk up. Here was the notion that instead of looking at each individual trial and giving it a rating according to the quality of evidence, and I was never that interested in how many trials were this and how many trials were that. What I really wanted to know about as a clinician was what was the evidence in terms of clinical outcomes. Here we are in the GRADE approach looking across studies, eventually, at the overall quality of the evidence or our confidence in the effect estimate for given outcomes. So here one can imagine in an example for, say, ACE inhibitors in heart failure, we might have high quality evidence on mortality, maybe moderate evidence on symptom control, maybe less good evidence for quality of life, for example. But looking across the studies rather than looking study by study. And that always seemed to me to be much more meaningful to me as a now retired clinician. So last time I came to the BMJ, it was really important, the interactivity question was really important, so I had to ask questions and people had to vote. But I gather you don't have a vote. So I was going to ask you all to list 5 characteristics that would increase your confidence in an effect estimate. I'm slightly daunted from that. I think we might just move on and look at how the GRADE group did it. So the idea is that randomized evidence is by nature the highest level of quality. And so randomized trials start through the GRADE approach being judged as high quality, whereas observational evidence starts as low. And there are 5 factors that can lower the quality of evidence. They're listed there. I'm going to go through them one by one. So first is the methodology quality, the quality of conduct and reporting of the trials. And Doug's been talking about that already. There'll be features that are familiar to you. Lack of information about allocation, concealment, inadequate blinding, loss to follow-up, that sort of thing. So the methodology quality clearly at some level can influence your estimation of quality of the overall evidence estimate. The next thing would be inconsistency. So clearly if you have a forest plot where all the dots are lined vertically on top of each other, we might be quite confident that that's a true effect. Where they're scattered all over the page, you may find that your confidence in the overall diamond at the bottom is reduced. So variation in size of effect or limited overlap of the confidence intervals, the statistical significance of heterogeneity or a high I-squared. These are ways that one might make judgments about the variation in the effect estimate across the different trials. But of course, in part of this assessment is looking for an explanation of inconsistency, because there may be perfectly rational explanations which may not cause you to downgrade your estimate of confidence. Oops. Here's a slide that tries to show that. Here you have the various trials and the effect estimates sort of all over the place, reducing your confidence in that diamond there. And indeed an I-squared, which is high at 88%. So then there's the question of directness. And this often relates to how directly the evidence relates to perhaps the patient in front of you or the health system decision you have to make. And that may be because of indirect comparisons. In particular, for example, if you're interested in the comparison of drug A versus drug B, but only have trials of each against placebo. Or there may be because of issues related to the PICO features. So is it a different population? So in this example, is it early stage versus end stage cirrhosis? Is it flexible sigmoidoscopy versus rigid in colorectal cancer screening? Is it a different dose in the comparison? Or are we looking at a symptomatic ulcer or just an ulcer seen on endoscopy? And finally, fourth out of 5, we have imprecision of results, and here's a picture of another forest plot showing quite considerable imprecision of results, causing again us to think about reducing our estimation of confidence in the effect. And finally, publication bias, and here on the top of the slide showing the published studies looking at antidepressant drugs, and subsequently all the trials, including the unpublished studies, showing a much more balanced distribution and evidence of publication bias. But there are also factors that increase confidence in the effect, particularly in observational studies. So, for example, in the parachute example, apparently the data show that 99.9% of people who jump out of an aeroplane with a parachute survive, which probably isn't true if you jump without. So you may be prepared to accept a large effect as being increasing your confidence in that estimate. A dose response. So, for example, there's evidence that radiotherapy given for malignancies can increase the risk of a later malignancy, and that rate increases if the amount of radiotherapy increases. So a dose response. And finally, this rather confusing third bullet, all possible confounding would reduce the demonstrated effect, which the example I always give is in the States, not-for-profit hospitals do slightly but not fantastically better than for-profit hospitals. But that's particularly, then you have to then consider that the not-for-profit hospitals are looking after people who are older and sicker. So in a sort of flat world, you might expect them to do worse, but the fact that they do slightly better increases your confidence that this might be a real benefit. I hope that's clear. I got it after about the 6th go. Okay, so this is a mistake I made. When I was editing clinical evidence, we were asked to do a grade on paracetamol poisoning. And this is simply to show that although the parachute example may be slightly extreme, there are also examples in real practice. And we graded the evidence here for treatment of acute paracetamol poisoning on acetylcysteine. And as you can see now, it's graded as beneficial, but that's only after we changed it, because our initial assessment was that it was moderate. And the reason we came to that judgment was that there was only one small trial of about 50 people that was non-blinded, and effective conceding allocation might have been inadequate. So we made the judgment that, and this is a bit more detail about the study, no blinding, very small trial, but a small benefit, a benefit even on those small numbers. So this is looking at acetylcysteine against no acetylcysteine. So as a result, my team and I came to the idea that this was moderate evidence because although there were no study limitations, it was a randomized trial, it was highly imprecise, we allowed for directness, there was fine, consistency fine, we didn't think there was any publication bias. And we left it at that, and the authors of the review went bonkers. And the reason they went bonkers was they said, we can't possibly show this to our colleagues because they will think we've lost our mind, you completely lost the plot. And the reason we'd lost the plot was that we hadn't looked for observational studies. And in fact, the data from observational studies is perfectly compelling. Here's a small study reported in the BMJ of people treated with acetylcysteine, of whom only 1 in 62 developed severe liver damage or an ALT greater than 1,000. And this was compared with a retrospective series of where almost 60% of people developed these changes from a similar level of paracetamol overdose. And here's a larger study looking at the same question largely, 2,500 people, same criteria, and here was 6% developing the criteria of treated within 10 hours and 26.4% treated between 10 and 24 hours. So what the authors are saying, and I think probably in retrospect I agree, was that actually there was no reason to call this moderate evidence. This was quite compelling evidence of an effect from this drug. And that's I'm trying to show an example of how you can upgrade the evidence based on observational trials. And here's a summary of the changes, starting with high and low, randomized and observational, looking at these 5 criteria for potentially downgrading, and these 3 for potentially upgrading your estimation of the confidence in the effect. And this is the definition the grade group used, talking about confidence that the true effect lies to that given. We're very confident, we're moderately confident, our confidence is limited, and we have very little confidence at all. And these groups have adopted grade across the world, so it's likely that people who are coming across systematic reviews in the future will frequently see grade being used to measure the quality of the effect. And this is a grade evidence table, and I think it's probably useful to think about how these, to look at this in a little bit of detail. So the important thing here is here we have the PICO question that's being asked. We then have the table organized by rows. So here we have each of the 4 outcomes, and you usually have up to 7, and one of them is usually a harm or side effect. The question was, should parenteral anticoagulation be used for a patient with cancer? And you have the evidence here from 5 trials. These are the indicators we just talked about. These are the results, in both in relative and absolute form. This is the quality of the evidence. So here on this slide, you have all those 4 elements. Here you have, is there an effect? What's the direction? What's the size? And how confident are you in that effect estimate? And possibly interesting from a sort of clinician point of view, and maybe from a policymaker view, you can also rank these by the importance of that outcome to that individual. So it may well be that a policy group or a guideline group does a particular piece of work looking at what the empirical evidence of patient preferences is, or it may be that the patient in front of you can supply that for you. So taking a stereotype, when I'm 105 and somebody tries to give me ACE inhibitors for heart failure, my question will not be, will it make me live longer, but it will be, will it make me less breathless, will it improve my appetite? So I may regard the evidence, the outcomes with a different view of importance from the standard way. So this is an evidence table, still quite complicated to look at, and that's summarized on the next slide. Same data. Here's a summary of findings tables, and again, arranged by rows. Here we have the results, relative and absolute. We have the number of studies and participants, and the grading of evidence, and a line for comments. And these, it should also be possible to look at the superscript and find the reasons for why the evidence is up or downgraded. So the key benefits, I would say, are there's standardized quality of evidence, it's transparent, and you can customize the outcomes on the basis of patient priorities. It's more intuitive, so we're not counting studies, we're looking at outcomes across studies. And that, I think, may help in terms of that triad of assisting decision making. Limitations: the evidence ratings for alternative management strategies, no, not risk or prognosis per se, doesn't eliminate disagreements. It's perfectly possible for people to look at the same evidence and come to different views about the quality of the evidence. And it clearly requires some training. I'm going to talk briefly about grading recommendations, a separate activity. Again, we can think about, I think sometimes in the past I've made the mistake of thinking that a high quality evidence and a strong recommendation should always go hand in hand. But a strong recommendation can be made for no treatment, clearly. So it may well be the strong recommendation is because the trials were well conducted and reported, maybe a large or precise effect, and there may be few downsides of therapy. Whereas a weak recommendation may rely on poor methods, or an imprecise estimate, or need a small effect compared to substantial downsides. So it's not always the case that a strong recommendation is caused by high quality evidence. So to sum up, to finish, grading seems to be getting acceptance as an international standard because it adds value. It has criteria for evidence assessment across a range of questions and outcomes. It's sensible, transparent and systematic, and there's a balance between simplicity and methodological rigor. And that's what I think, particularly for me as an ex-clinician, makes it a highly attractive option in thinking about shared decision making. Thank you.
We've actually got sunshine in the UK, so we had to dim the blinds while you're there. Any questions for David while he's in his new role, which I guess he's still finding your feet? Okay, I'm going to. There's a question there at the back. Just back a bit.
My name's Marnie Brennan. I'm from veterinary school, actually, at Nottingham, so it's a bit of a left field question here. We are in the process of setting up some, I guess, reporting standards or ways of looking at the evidence that we've got in the veterinary field. And just having a look at what's in the medical field and the different, I guess, things like grade that are around. Is there a danger that there's lots of different types of methods that people can use and there's no clear way forward, like in terms of comparing studies with each other? If there's lots of different types and people are developing new ones, is there a danger that we're not pulling in the same direction, potentially?
I think that there clearly is a danger. I think that what the grade group would say is that the importance is transparency. So you can look at the data and I can look at the data and we may come to different conclusions, but the reason that we came to those different conclusions should be transparent to the next person that comes along and reads whatever it is we've written. Clearly it's a risk, people doing things differently. But that's, I guess, that's the downside of sort of methodological advancement, that things change, right? And but it seems to me that the most important thing is transparency. It's of secondary importance whether everybody agrees.
On the right.
David, that was excellent. As a member of the grade group, I'd have to say that was the clearest explanation of grade that I've ever seen. So congratulations on that. Just one comment on that, and that was grade can only really be done if a systematic review is there. So it's grading the quality of the evidence related to a systematic review. But there are lots of questions for which we don't have a systematic review done, and they take several months to years to do. So we still do need some other system when you don't have a systematic review done. And I just wanted to mention the Centre for Evidence-Based Medicine levels of evidence we've actually revised so that it's pointing out that it's actually a search heuristic, that you look first for the systematic review, which hopefully has been graded, but then what do you do if you don't find one? And we no longer relate those directly to a grading level, but say you should go and look at the grade process.
I have a question which just came up, if you don't mind, David. You said sometimes there's randomised trials and then you should use potentially observational data, and you gave a very good example to grade the evidence. Is anybody working on criteria, or are there criteria when you should use observational data to support?
I mean, clearly lots of people are working on it. I was lucky enough to be at a conference in Ottawa on that exact subject earlier this year sometime. What's clear is that there is no, and it seems to be clear to me anyway, that there's no great consensus about this at the moment. There are people at one end of the spectrum, particularly people doing systematic reviews in public health, looking at questions like slum clearance, that sort of thing, where they virtually regard, where randomised trials are really almost unthinkable, unfeasible, and therefore looking at non-randomised studies will be the rule. And there are other review groups working in, say, more clinical disciplines, where it would be very unusual for them to look at non-randomised studies, and they would expect to find all the information that they need from randomised studies. So I guess somebody from one of my colleagues said once, basically, you know, if you have the information you need on the patient outcomes you need from randomised studies, maybe you don't need to look at non-randomised studies. But where that's lacking, and that's not infrequent, then you know there is a good reason to look at non-randomised studies, and in particular for the question of harms, and in particular delayed serious harms.
Okay. One last question here. Oh, right, one more, and then we'll get your refreshment.
I wonder if you could speak to the issue of standardizing the way that the risk of bias tool is being used. If you look at, I'm involved in Cochrane systematic reviews, and some groups are developing their own interpretation and actually expanding on the 6 items that is in the risk of bias, which is a substantial portion of the grade system, how that's factored in.
Well, I'm aware that Doug's on row 2, so I'll be careful what I say. We have a handbook that explains how you should interpret the risk of bias, and in general, review groups should go by the handbook. Now, a number of review groups have attempted to interpret the risk of bias tool in their own discipline, which I think, and I think probably Doug thinks, is an okay thing to do. I think what's less okay is when people start inventing new criteria or adapting existing criteria for their own purposes, and in particular if they go down and pick things that seem broadly arbitrary. But I don't know whether you want to comment on that, Doug, but you know, Cochrane review groups should be working to implement the Cochrane handbook. They have a bunch of software to help them do that, and you know, more than interpreting the guidance that's there, I think that's what they should be doing. I don't think they should be going beyond that. Does that answer your question?
One last question at the back here, and then we'll break.
Thank you. Roger Greenhouse, surgeon, described sometimes as being obsessed with performing randomized controlled trials, which is unusual in surgery. I think it's important to recognize, as I've had to do, that there are some situations in my subject where a randomized controlled trial is simply not an option. And I give you one example. For example, the Fogarty catheter, which was invented, and this catheter was so obviously beneficial that it would be unthinkable to do a randomized controlled trial. Fogarty passed a balloon catheter into arteries and veins and blew it up and pulled out the clot through a very tiny incision. Until that time, massive surgery was required. It became obvious overnight that that was a major advance. I wonder whether your system, as you described the pyramid eloquently, whether you and where you would fit that experience into it.
I think that, I didn't absolutely catch the example, but I think what you're talking about is an example where there's a clearly large effect. So if you were to you take the grade approach to that and you were look at observational data that showed a substantially large effect, you might then consider that this was sufficient to upgrade your rating of the evidence for that particular intervention from low in observational studies start up to high, depending on the extent of the effect and your confidence in that. Clearly, if somebody comes along with another type of catheter, it may be perfectly appropriate to trial that in a randomized trial against the first one. But at the outset, as you say, it sounds as though there's such a high magnitude of effect that a randomized trial might legitimately have been unfeasible.
Okay, I'm going to stop you there. Thanks to Doug, thanks to David. Coffee, refreshments, poster viewing, and if you're going to come back to this room, Fiona Godley is going to introduce Ian Chalmers at 3 o'clock on the dot. Thank you.